All right. Hello, everybody. My name is Anthony. I am a clinical pharmacist here today. My specialty is medication. So today my presentation is going to be on mineralocorticoid receptor antagonists and SGLT2 inhibitors. Moving forward, I'm just going to call them MRAs and SGLT2s because those are some big words. We're going to look at kind of how they work in heart failure. Not only just like how they work and how we use them, but also the evidence that we've kind of seen over the years to really justify their use. So can we go to the next slide? So learning objective today, we're looking for the really big targeting pathways, but the SGLT2s specifically in heart failure.
Uh, let's
We're going to
turn the camera
describe
up.
the
Anthony,
current
we just
guideline
lost
based.
you. Yeah, we just lost you again. So if we can.
No, no worries. We'll try it this way, and then if it doesn't work, we'll have to call in.
Okay.
I'll just restart. So we're going to identify the pathways that are targeted by these two drug classes in heart failure. We're going to describe the guideline-based recommendations across the spectrum. That includes HFrEF, HFmrEF, and HFpEF. And then we're also going to look at what are some practical considerations for implementing these use, including patient populations, monitoring, and some adverse effects. Go ahead, next slide. So first thing we want to look at is what are these two drugs classes kind of targeting? And when we're looking at the MRAs, we're looking at the renin-angiotensin-aldosterone system overactivation. This can be, caused by stress on the heart, just in general. It's called the neurohormonal pathway. It also includes the RAS overactivation, also includes, along with that, also is included the sympathetic nervous system. It's kind of just this crazy feedback loop that just leads to excess aldosterone, causing bad things to the heart. If we're going to be kind of crude about it, we're going to be scarring, fluid retention, and so the what we're targeting here is the mineralocorticoid receptor that accepts the aldosterone. We're trying to slow down that damaging effect. The second one is the cardiorenal metabolic dysregulation. This one's really interesting. A lot of studies are being done on it right now. It's a novel pathway, but this is really a big feedback loop. It in general, it's really just the body mismanaging its use of substances leading to poor heart energy use and kidney strain. The kidney gets it's a really, when I say about feedback loop, it's the kidney causing strain on the heart, which causes strain on the kidney. So it's just this really bad feedback loop. So what we're looking to do there is target the sodium glucose co-transporter 2 or the SGLT2 the SGLT2 inhibitor. All right, next one. So first thing we're going to look at is the MRAs. Typically, you have two classes, the steroidal versus the non-steroidal. The non-steroidal are kind of a newer class, more recently being studied. And that includes finerenone. But your classic ones that most everyone has heard of is really spironolactone, that's been around a while, and then eplerenone. The steroidal ones have a very good track record in HFrEF, which is your heart failure ejection fractions less than 40%. Really good established long-term mortality benefit. The one thing that is kind of concerning about it is their risk for hyperkalemia and use in chronic kidney disease, specifically like, once we get down in EGFR levels of less than 30. That's where kind of finerenone comes in, less effect on kidneys potassium balance to leading to a lower risk of hyperkalemia. And then also, as we'll kind of see moving forward, they have actually shown pretty good benefit in HFrEF and HFpEF, which is your moderately reduced and preserved ejection fractions, along with diabetic kidney disease. Next slide. So with SGLT2 class, we are looking just beyond the effect of, what it does in diabetes, which I always tell, this is what I tell docs and patients is what you're doing is you're peeing out sugar. It helps to get rid of excess sugar so that our body isn't holding on to an increase in our blood sugar. So but what we're finding with heart failure is that it has a lot of effects beyond this. I think they call it pleiotropic effects. That's a cool word for the day for everybody. It just means multiple different modes of action for it. So the energy boost, it found that it shifts the heart fuel source to a more efficient compound. Going deeper in depth to that, it's like it burns fat, so it uses ketones Ketones can be kind of a double-edged sword, leading to diabetic ketoacidosis, but it's pretty rare. So, but in reality, what it is doing is it is helping to improve cardiac energy. It works directly on the heart to regulate minerals. You have improved pumping, you have improved rhythm, and then also causes moderate fluid removal and relaxes blood vessels, reducing the heart's workload. Now, all of these things that you see on here, and also renal protection, reduces the high pressures. All of these things that are positives are also all things that can be kind of things that you have to watch out for in the use of this medication. So we can go ahead and go to the next one. So in HFrEF, we kind of mentioned this, it's your ejection fraction less than 40. How are they kind of moving into more like how we use this and how we implement it? So we talked about the four pillars. We talked about GAD-MT. We've kind of talked about that all the time. You know, it's always want to try to initiate all four of these classes in up titration. This is all class 1A level of in the guidelines. So we see ARNIs, ACEs, ARBs, and then evidence-based beta blockers, with the two that we're focusing on is MRAs and SGLT2s. So next slide. Some of the trials that we have looked at over that, the guidelines reference that have used or that they have used to really cement their place in use in HFrEF were the rails, the ephesis, and the emphasis. In the rails trial, we found that that spironolactone cut the risk of all-cause mortality and severe HFrEF, which is like your New York, Hospital Association, I think it is 3 or 4 class, by up to 30%, which is a pretty big cut. And then in your thesis, it also showed not only that it helps with HFrEF, but also that it is a mortality benefit for people with HFrEF that also have an MI. So, and the emphasis, which is more of a recent one with it, just more of the same, significantly reduced cardiovascular death and heart failure hospitalization, not only in severe but mild HFrEF. So sustained long-term survival benefits for patients that have HFrEF that are on this medication. Next slide. Some more of the SGLT2 ones. We look at the DAPA and the Emperor reduced, consistently reducing the risk of cardiovascular death. And then one of the interesting things that came out of these studies was that the benefit was seen really quickly. You could see on the top right, what you see is the reduced risk of heart failure or death, and of heart failure exacerbation or death. And you could see that it's in less than 3 months. They actually saw it within 30 days that curve starts to diverge, and we are seeing benefit really quickly from SGLT2s. So the immediate clinical benefit and pretty good safety profile makes the SGLT2s really good choice to be put in HFrEF. Next slide. So then we can move on. So that kind of like established HFrEF, HFpEF. It's kind of like, yes, we want to use MRAs, we want to use SGLT2s in these. But what happens when heart failure is not quite down into that, reduced ejection fraction, or we could be in moderately reduced, or we could be in preserved. So we see with HFpEF, really highly complex, often driven by comorbidities. We really want to focus on reducing hospitalization in these patients. And then with HFrEF, really dynamic. A person could be coming from HFrEF into HF and moving their way to HFpEF, or they could be in HFpEF going down into HFrEF. And I know I'm using a bunch of analogies, but it could be getting worse or it could be getting better. So we do see benefit from multiple drug classes with HFrEF. Next slide, please. So moving back to the MRAs, what are we seeing, with this one? This is where we really see the advanced efficacy and use of finerenone, the non-steroidal MRAs. We look at the top cat. This was an interesting trial when I started digging into it. I'd heard about it. I'd heard about it in school being like, hey, it does help, or it really showed nothing. What I didn't know was that they saw an overall neutral effect, but it had two arms. One was in North America, and the other was in Asia and Russia. And what they ended up finding was that it did show a benefit in reducing hospitalizations in the North American group. But when they looked at the Asian and the I think it was Russia was the other big part of the arm, they found that it was very possible that there was really bad non-compliance with the medications. And so that actually affected the study, showing, that When they published it, it's like maybe not, but in reality, if you separated it out, we may have been seeing actually a pretty good benefit. The finerenone's trial, though, the Fine Arts HF, it did show a 16% reduction in total worsening heart failure events or death from cardiovascular across the HFmrEF and the HFpEF. So what the guidelines kind of did is say, hey, finerenone is a really good is a very good use, or we could find a very good use for this drug in this class of patients. So next slide. Then with the SGLT2s, we look at the emperor preserved and the deliver, consistently reducing the risk of cardiovascular death in this patient population by 18 to 21%. The pooled analysis, there was a slide a couple ones ago. It actually showed the pooled analysis of it showed the data of all the studies that were done across the heart failure spectrum, and it really did show still a good benefit. I think it was the risk or the risk was like 0.77, so like 77, like a 23% reduction. So guideline impact, the SGLT2s have now gotten a class 2A. It's reasonable to use. It's not quite as strong as the HFrEF use, but it is a recommended, reasonable to use in all patients with the ejection fraction of greater than 40. So next slide. Special populations, we look at diabetes. SGLT2s are a cornerstone of treatment in diabetes. So it is class 1 for type 2 diabetes, along with cardiovascular disease and high risk. It's kind of goes back to that cardiorenal metabolic pathway. It's kind of like you're killing two birds with one stone with it. So it's a great drug. And then with MRAs, it's still effective regardless of your type 2 diabetes status. In chronic kidney disease, generally safe down to 20 mils per minute of E for eGFR. It slows the progression of CKD. As a matter of fact, SGLT2s are this great, like, just quiver of one drug for like 3 or 4 different disease states. And, you don't need to have everything together to have this. You could have just diabetes or you could have just CKD, and these medications are great for it. Unfortunately for the MRAs, you kind of have to keep an eye on the eGFR with this one, just because it has shown that it can affect it a little bit. That's kind of where the finerenone may come in a little bit, but we still got to look at how well the kidney is filtering. Potassium, we're not really worried about the SGLT2s. As a matter of fact, because of the diuretic effect that they have, it might mitigate the effect that MRAs have on increasing the hyperkalemia. And with MRAs, we want to make sure that we're only initiating if the potassium is less than 5, and it is okay, like Dr. Longenecker was talking about a couple weeks ago, if to keep it on if as long as the potassium does not go above 5.5. Post MI, we're seeing that both of these medication classes have roles in reducing in heart failure stuff after MI. So next one, please. Onto the practical considerations. This is where like your clinical pharmacist can help you out, with helping out, like, hey, what do we got to look at? What kind of patient specific factors do we need to look at? With your MRAs, your non-steroidal or your steroidal ones like your spironolactone or your eplerenone, really watch the hyperkalemia. We got to check it at baseline. They recommend 3 days, 7 days, and then monthly for the first 3 months. I realize that you guys in rural areas, this might be difficult. What we tell everybody here is just do the best you can. We usually say if someone is going to be started on spironolactone for heart failure, at least get them back in a week, or just have a standing lab order for it. If the MRA, hold the MRA if the potassium is greater than 5.5 or if the eGFR falls below 30. Another kind of bummer adverse effect of spironolactones more often in males than females is it can cause gynecomastia. Fortunately, there are other MRAs now that you can switch to, such as eplerenone and finerenone. And then also use caution with NSAIDs, which it says it can increase the risk of hyperkalemia. I have yet to see a case where somebody's been on ibuprofen or an NSAID along with it in it, but it can happen. So just be aware of that. SGLT2s, specifically dapagliflozin or empagliflozin. Dapagliflozin is Farxiga and empagliflozin is Jardiance. Volume status can cause hypotension. If patients are on loop diuretics or any diuretics for that case, is what we've kind of seen. Really kind of keep an eye on, maybe, if someone comes back and you're having issues with hypotension, look at any of the diuretics. We've actually even stopped some people on hydrochlorothiazide or chlorthalidone before. Not saying it's going to be as pronounced, but still, we just have done it because we'd rather have somebody on the SGLT2 rather than like a thiazide. The rare serious risk, this kind of goes back to the heart using ketones as an energy source. Euglycemic DKA, very rare, but it can be very serious. Your patients will end up in the hospital if it does happen. Just make sure they're keeping it. What the package insert say is hold the drug 3 to 4 days before an elective surgery. I didn't look into exactly why before an elective surgery. It might just be because of stress on the heart, or if you're serious. One of the more common effects that we see, especially in women, is gynecological effects, gynecourinary. Um, it says mycotic infections are very are more common. I have yet to see a mycotic infection from it. I think that they're pretty rare. What I see more often is yeast infections or UTIs. And I think that comes from the fact that you may urinate a bigger portion of sugar out, and so it just kind of creates a breeding ground for either fungus or bacteria. Make sure to counsel patients on hygiene, and then if you do get it, it's managed with standard antifungals or common UTI treatment. Right, next slide. Slide just kind of summarizes where we're kind of looking at. We do see, in HFrEF, we have class 1A recommendations for both drugs, whereas HFmrEF and HFpEF, we're kind of seeing a little bit more, but it still is reasonable. We're seeing more and more studies all the time that kind of move these recommendations a little bit more towards they may be more beneficial to be used in these populations. So, all right, next slide. So finally, our key points, we want to do immediate action. We want to start and optimize all 4 pillars of the GDMT therapy as soon as possible in FREF. I say that with one caveat. We want to try, when it comes to optimizing, still like watch out for the patient effects. We have seen patients end up in the hospital because they come out and they're not being followed. More along the lines of for kidney issues, because we're on a bunch of drugs that can kind of dry your kidney out, or if they're all taken together and your kidney just can't handle it and overload it, you could end up with some issues and then end up in the hospital. So I say that the only caveat there, definitely do it, but try to make sure that we're keeping a close eye on your patients. Broaden the application. We're looking at SGLT2s in more use in patients with the EF of greater than 40%. Consider finerenone, particularly in patients with greater than 40% or with high risk of hyperkalemia, to also get that MRA benefit. Monitor closely, kind of goes back to that first one. While the potassium kidney functions are required, still manageable side effects should not prevent the patients from getting these medications, or it should not scare providers away from getting these medications, as long as we have the tools and the ability to kind of keep a close eye on them. And then my final thing is optimal management. We're looking for early initiation of these therapies to improve outcomes across not just HFrEF, but also all the heart failure spectrum. Thank you, guys. I really appreciate the time. Any questions there for me?
Well, thank you so much, Anthony. That was fabulous, very clear, and lots of great information. So I'll open it up to anyone. You can feel free to raise your hand, put the questions in the chat. And while we're waiting, I'll go ahead and start things off. So I have a question about costs and reimbursement, because I think that's always on the minds of everyone here. And so, Anthony, what has your experience been? I'll start with finerenone, then we can go down to SGLT2 inhibitors. Are you having any troubles getting these for your patients?
Finerenone a little bit more. And that's where I think it's important. We're very fortunate here at our clinic that we actually have a dedicated prior authorization pharmacy tech.
Mhm.
And I understand that a lot of clinics don't have that. But the prior auths haven't been that complicated to get finerenone covered. But we definitely have seen where they would rather you try spironolactone or a eplerenone first. And that's or have to show that this patient has an issue with hyperkalemia, and it's as long as the biggest thing that I can say there is just make sure you document really well, because these insurance companies do like seeing the documentation. And if you can know kind of those realms of where finerenone would benefit your patient, and you say, hey, my patient, is not a candidate for this because we're worried about his kidneys, we're worried about the potassium, it's usually come across that then they like to cover it. Now, as far as cost, that's a tough one just because of it is a high cost drug right now. But most insurances cover it at a pretty, especially like your Medicare would cover it at a pretty good copay.
Great. Yeah, are you seeing like in terms of having failed one of the steroidals, like is there a potassium cutoff that you had to have achieved or some
Honestly, for us, it wasn't. I think we have seen this, and I did ask our PA tech the other day. And he says that you don't necessarily have to hit that 5.5
Hmm,
mark with
yeah,
the potassium, because usually in across the entire spectrum, like usually if it's going to throw alarm bells at you if you go above 5. So
yeah,
if you can document that the patient is going above 5 on spironolactone, then it's usually not like, hey, this patient has to be absolutely above 5.5. So I did ask him about that, just to make sure like that they weren't like, because in my realms, I'm like, okay, if someone's trending above 5, like let's go ahead and try something else instead of just trying to keep pushing this until you hit that 5.5 mark. So yeah.
yeah. Great. And I'm going to ask one more question while we wait for some others, and then I'll popcorn to some of the other panelists. Um, what do you counsel male patients that you may have about the anti-androgen effects of spironolactone besides the gynecomastia? These are obviously lower doses than what might be used for, gender affirming care, at higher doses above 50.
Mhm.
But do you see things like decreased libido or other sorts of anti-androgen effects?
I haven't, not with spironolactone. With what I have seen, when I and this comes more from, if even if we're going away from like not even our heart failure patients, I haven't seen a ton. The only thing that I have seen is more along the lines of, it's not necessarily libido, but it's just a tired feeling. They
Hmm,
just almost feel a little bit tired. And I guess you can consider that an anti-androgenic effect. And usually what we end up doing with male patients is we don't have a ton of people with heart failure on it, but I still make sure to start them out at a lower dose than just the 25. Usually, like if we move on, and it's like usually for like resistant hypertension, I'll be like, hey, I'm gonna start you at 10 just because we've had people complaining of just fatigue and just general
hmm,
blah feelings on the spironolactone. And so, yeah, when you look at it, that could definitely be contributed towards the antiandronergic.
yeah.
I've only seen like maybe one or two people throughout my 10 years that have actually had the gynecomastia from the spironolactone. We usually rely on it, not just for heart failure, but we rely on it really heavily for that resistant hypertension as well.
Yeah. And I've had a similar experience, although in my practice I have a number of people for whom it's kind of like statin myalgias. They read the package insert and then they get those effects even though it actually probably is not. And
The
so
the, the good
uh,
old nocebo effect.
yes. So we have a great question in the chat from Brian. So if spironolactone is 10 and finerenone is 1 on the kind of risk spectrum for hyperkalemia, where would eplerenone fall? Like, is it the same as spironolactone, or like, is it like a 8, or is it a
I
5?
would put it I would put it more on the I would put it more towards the ends of spironolactone. I have yet to see anybody come back with hyperkalemia on finerenone. Now I'm talking about an N of like 5 or 6 in our small little
Sure.
practice.
Yeah.
But it is something I keep a little bit closer look on with a Plerinone. To make sure when we throw people on finerenone, I'm like, hey, we don't really have to worry. And when I say that, like when I put it into practical considerations, if someone lives 2 hours away and they're like, hey, I can't get back, in a month or 2 weeks to see you, I'm like, with finerenone, I'm not as concerned as I am with eplerenone and spironolactone. And so that may come, I don't know the actual like differences in the studies on it, but that's just been my personal experience. Like I with eplerenone and spironolactone, I push more along the lines of I want you back within a week to two, where finerenone I'm a little bit more lax with.
Great. Yeah, so yeah, please add other questions to the chat. Maybe I can now ask Sean, given, the gynecomastia that we see or hyperkalemia or whatever with spironolactone, why don't we just routinely use eplerenone in everyone? Why do we tend to use spironolactone more?
Well, usually it's just for availability and it's much cheaper and honestly preferential to insurance companies is probably the main reason why we start there. And honestly, for most of my patients, I think it's well tolerated. Rarely do I have to switch to a Pleuronone or a different kind, despite all the, possible adverse effects.
Yeah, yeah, well said. I think that's also been our experience. Um, Anyone else from the panel want to weigh in with any questions?
I did have something else, with the SGLT2 inhibitors. I get a lot of elderly women, who are very hesitant when they read about UTIs because they've had a hospitalization once and, maybe they had some altered mental status. And so, I talked to them about it. I was like, okay, well, good hygiene and all these things. Is there a point in anybody's experience where, say, there's a number of UTIs or a degree of, severity of a UTI where, you would say, maybe not anymore.
Yeah, what do you think, Anthony?
And like I said, this I don't take this as gospel, but when I have a doc come up to me and ask about it, if they've had one or so in the last year, not super concerned over it. Or if they've had like one in the last couple of years, when the docs kind of get concerned about it and we kind of are like, maybe like let's not take the risk. It's if they're kind of like if it's every year they're getting one, or if it's multiple times in a year, then we're kind of like pushing, then we're kind of pushing the at least yield button. And it's once again where we're like, hey, we're just gonna start you on a very, heart failure. I think the with Jardiance, it's 10 milligrams, and is what they kind of talk about with heart failure. We may be like, hey, we're gonna start you off on half a tab, not and it even though the adverse effects still may be the same, it's kind of like that myalgia where we're trying to work with the patient. We're trying to make shared decision making. Like, hey, let's just start you off with half, see what happens for a couple weeks to a month. If you're cool with that, then let's get you up to 10 where we want you to be at. And we found some pretty good luck with that, especially with the more hesitant patients to be like, hey, I'm kind of worried about this. I've had one in the past. It's been a couple years, but still kind of concerned about it. So, yep.
Mm.
Bill says in the chat that he's prescribed vaginal estrogen for a 73-year-old, and that has worked. Great. So can I, yeah, you mentioned the half dose of empagliflozin, or cutting it in half. Can you talk, Anthony, about dosing with dapagliflozin? There's actually a 5 milligram tablet, right? Do you ever start someone on that 5 milligrams of DAPA?
You could. We see insurance companies nowadays covering way more of the Jardians, and so I honestly haven't seen Farxiga in a while.
Mhm.
And usually it's just like if someone had been on it prior to the mass adoption of Jardians. But yeah, I could totally see you doing that. Yeah, and now, like I said, not like if we're looking at HFrEF and we're looking at you want to get somebody on that 10 milligrams as fast as possible and get it up to it. Like I totally and completely understand that. Also, if you have a patient that is so worried about the UTIs and is like, I'm not even going to take this, and you're like, well, I can't do this because the HFrEF, the guidelines say I need to get you to 10, and you're like, sorry. And so So it's just something that some of the providers here have been like, hey, let's just start them off with the half, see how they do on it, and then that way we can just get them off of it. And if they don't like it, if not, we'll get them to the right dose.
Yeah.